Hello, and a very warm welcome to you all for this third webinar in this 5-part series focusing on racial inequality in maternal healthcare. My name is Olivia Boschat, and I'm an associate solicitor in the women's health team at Bolt Bird & Kemp. Alongside my colleague Hannah Travis, I'll be hosting a few of these webinars. I am delighted to welcome our speaker for today's webinar, Dr. Christine Ekechi. Many of you will already know of Christine, as well as being a consultant obstetrician and gynaecologist at Queen Charlotte's and Chelsea Hospital in London. She is also co-chair of the Race Equality Taskforce at the Royal College of Obstetricians and Gynaecologists, and also their spokesperson for racial equality. She is the ROCOG clinical champion for the Women's Network, and she is dedicated to women's health. She is a women's health educator and advocate and is committed to maternity safety. She works with many charities, networks, and other organisations. I could go on for some time discussing her impressive CV, but I will stop there for now. I'd just like to say how extremely grateful we are to Christine and how very fortunate we are to have her join us today. In today's webinar, Christine will be tackling the wide and important topic of racial bias in women's health. It promises to be a really enlightening session. 2 quick housekeeping points before we begin. Firstly, like the other seminars, there will be a question and answer session at the end. If you have any questions, please pop them in the Q&A box at the bottom of your screen and we will come to them later. Secondly, you'll be aware that these webinars are being recorded and a copy of the recording will be sent out to all attendees after the session. Please do feel free to share the recording with colleagues if you think it will be of benefit to them. So now I'm very pleased to hand over to Christine to begin her talk. Thank you.
Thank you, Olivia, and thank you everybody for joining me today on what is a very grey and dreary afternoon. I'm going to go ahead and share my screen, and as I do, I'm going to mention that this talk, I'm going to broaden it out. So whilst we are well aware of the data around the differences in outcomes in maternity, often what we are less aware of is the replication of some of these differences throughout the life arc of a woman. And for me, this is vitally important. If we wish to try and reduce the differences in outcomes that we see in maternal outcomes, then really we need to start right from the beginning. Just as Hannah described, I'm a consultant obstetrician and gynecologist and wear many hats. But really I'm speaking to you as a woman from a minoritized background, and also as a clinician. So I start with this slide. Many of us would have seen many iterations of this slide. Keep calm, we're all in this together. But really the question is, are we? And I move on to this slide just to remind us all that when we are thinking about racial equality, this is not just a moral duty. There's also a legal duty. And I remind everybody of the UK Equality Act of 2010 that makes it unlawful for us to discriminate against people on the basis of their membership of a group with a protected characteristic. So that can range from our gender, our sexual orientation, and religion, but in particular today, we're going to use the lens of race. And I just point out that just because I am during this talk using the lens of race, it doesn't mean that using the different lenses, so for example, gender or disability is not important. In fact, it's vitally important. And I'll talk about that a little bit later. So unfortunately, we can never tire of repeating this particular statistic, of which many of you may be aware. And that is that in the UK, we have stark differences in the outcomes for maternal mortality when we use the particular lens of race. I should say, and it's important for me to hammer home, that maternal mortality in the UK is thankfully extremely low. And that's a statistic that I am extremely proud of. However, when we look at the outcomes between women of different ethnicities, we see the stark difference. And in particular, what we do understand is that Black women are 4 to 5 times more likely to die in pregnancy or soon after compared to white women. Asian women are twice as likely to die, and women that are determined to be of mixed ethnicity are 3 times more likely to die. When these statistics first hit the public consciousness, probably around 2018, it generated a lot of column inches and a lot of discussion. And these are just examples of some of the news articles that some of you may remember seeing in 2018 and 2019. But what many people are not aware of is that this is not a new statistic. In fact, if we are to look through some of the historical confidential inquiries, which the names of the reports which looks at maternal mortality outcomes in the UK, we see that unfortunately for Black women, there has always been this stark difference in outcomes. So if we were to look at the report from 2000 to 2002, we found then that Black women were 7 times more likely to die compared to white women. And over the last 10 years, whilst we've seen some fluctuation in the difference in the mortality statistics, we've not really seen any meaningful reduction. The last report in 2018 showed that women were 5 times more likely to die, and the more recent report in 2020 gives us the more recent statistic of 4 times greater risk of death. So, of course, this is traumatizing. It is hard, it's difficult for us to swallow. But for me, the first question is this a statistic, when we use the lens of race, that is limited to maternity outcomes? And unfortunately, the answer to this is no. Some of you may have been aware of a Lancet series report. So the Lancet is a big scientific journal, one of the more impactful scientific journals, which looked at the outcomes of miscarriage. And in particular, what they found was that Black women had 40 times more likely or greater risk of suffering miscarriage compared to other women. Now, this was the first time that the lens of race had been applied, looking at miscarriage statistics. And of course, this has generated a lot of debate as to why this may be. Some of you may have seen the recent report last week from the BBC journalist Tulip Mundazar, trying to explore the factors that may contribute to this outcome. Of course, as I've mentioned before, we know that this outcome, looking at Black women and their poorer outcomes in maternity, continues to exist today. And unfortunately, Black women also suffer from a greater risk of delivering their baby early, a term that we use called preterm delivery. And this is a statement report from a big research group called the March of Dimes, explaining and defining the stark Black-white disparity in preterm birth. So one may say, well, maybe this is a problem that we only see when Black women are pregnant or in pregnancy. Really, unfortunately, again, that's not the case. And I wrote an article for the newspaper back in 2019 to point out that we see these differences also in our gynecological health and well-being. This is a 3D scan of a uterus, and the image to the left of the screen that looks like a round ball is a fibroid. Fibroids, we know, have a greater incidence and prevalence in Black and Asian women. Fibroids in of themselves are benign, but unfortunately for many women, they can grow to such a size that they can cause, for example, heavy and painful periods, with some women often ending up in hospital. Fibroids, depending on their location, may impact on the fertility of some women, impairing their ability to conceive or indeed hold a pregnancy for 9 months. And for many women, the best option to improve their daily lives is surgical intervention, of which carries significant morbidity, and in many countries outside of the West, significant mortality. But it's not just fibroids. There are many other gynecological conditions that we're now understanding can afflict women of certain ethnicities greater than others. Another example is endometriosis, a condition that we know suffers from a significant gender bias anyway. Endometriosis is a condition where the lining of the womb is found implanted within the pelvis of a woman outside of the uterus itself. over a long time without adequate treatment, it can cause scarring and in some instances cause infertility. The main symptom that women present with is pain and painful periods. And what we do know, because of the gender bias that exists, is that endometriosis for any woman, irrespective of their ethnic background, often has up to an 8-year delay between the first time of presentation with pain and the point at which they are diagnosed with their disease. When I was at medical school, we were often told that endometriosis was a condition that primarily affected white women and fibroids was a condition that primarily affected Black women. Now what we're understanding is that these brushstrokes generalizations are very much incorrect. I often give the anecdotal story that the most difficult hysterectomy I ever performed for fibroids was actually in an Irish woman. Conversely, what we're now beginning to understand is that endometriosis is a condition that affects Black women to the same, if not greater degree. We also know that many Black women have difficulty in feeling that they are being heard when they present with pain. So that 8-year lag time seen as an average is often much longer for Black and Asian women. Some of you may have been aware of the HFEA, that's the Human Fertilization and Embryology Authority, the authority in the UK that supervises fertility clinics and treatments. They published a report last year, April, looking at fertility outcomes, again, using the lens of race. And again, what they found is that Black women in particular were less likely to have successful IVF treatment, that is, to have a live birth following IVF, compared to many other racial groups. There were many other differences that they found, not least that Black women were more likely to present a year and a half later on average compared to many other women, and were less likely to find an ethnically matched donor, egg, or sperm if this is what was required. If we are to look at cancer, the one thing we do know is that we have a huge data gap, particularly when we try to apply an ethnicity lens. But we do know, for example, that Black women are less likely to attend for screening and more likely to present with more advanced stages of cervical cancer. In fact, we know currently in the UK, for all ethnicities, we are seeing the lowest uptake for cervical screening in the last 20 years. And unfortunately, the groups that affects the most are women of Black and Asian ethnicities and women of lower social classes. And it's important to remember that women don't only matter in the premenopausal state. Postmenopausal health is just as important. But again, we suffer from a significant data gap. From the little data that we do know, we understand that Black and Asian women are least likely to present with symptoms of menopause. Now, whether that's because they're less likely to experience symptoms of menopause or do not feel that they have access to treatments, we are still yet to understand. Now, we may all feel that we are coming through the end of what has been a traumatic 2 years with the COVID pandemic. But unfortunately, these ethnic differences was repeated even during COVID-19. This report by Embrace, looking at the maternal deaths of women who died with or from COVID, found that 88% of the women who died from COVID whilst pregnant were from Black or Asian backgrounds. And so essentially, in that quick summary, what I've shown is that these ethnic differences exist throughout the life arc of a woman. This report, titled Health Equity in England, published and authored by Sir Michael Marmot, gives a detailed look at the social determinants of health, or in other words, the social drivers, the factors in and around our daily lives that impact on our health outcomes. And what this report showed is that our ethnicity was a strong indicator as to our health outcomes. On top of that, our social class also had a significant impact. This paper, published by my colleague Asma Khalil, who's a professor of maternal medicine at St. George's and published together with the Royal College of Obstetricians and Gynaecologists and the National Maternity and Perinatal Audit, found that adverse perinatal outcomes were strongly associated with socioeconomic and ethnic status in England. In particular, what they found was that 64% of stillbirths in the most deprived of Black women and 72% of fetal growth restriction in the most deprived Asian women would not have occurred if they had the same risk as the most affluent white women. In other words, if this Black and Asian women had the same social circumstances as white women, they would have had the same outcome. So really, what does this tell us? Essentially, it makes us consider that having a Black or Asian ethnicity is not a singular driver to the poor outcomes. It is the socioeconomic status of these women that probably is the greatest driver. This Embrace report, looking at UK perinatal deaths for births between January and December of 2019, looked at the effect of ethnicity on perinatal mortality. And again, what they found was that mortality rates were extremely high for babies of Black mothers, and stillbirth rates were twice as high compared to white women. Similarly, mortality rates remain high for Asian women, as did the stillbirth and neonatal rates. But when they added socioeconomic status, they found that this further compounded the factors and confounded the outcomes, so that the poorest Asian and Black women had the worst outcomes for stillbirth and neonatal death. So for me, as you can imagine, over the last 10 years, I get sent so many of these reports to look at and to comment on, and to try and peel apart what may be the contributing factors to these awful statistics that we continually see. And for me, I find that I try to break it down into two main possible hypotheses. The first is that, is it individual factors which are overrepresented in Black and Asian women that are causing these differences in outcomes? Or is it societal factors to which Black and Asian women are more greatly exposed to that contributes to the outcomes? Well, I would suggest that it's probably a combination of both. And so when we're trying to consider why this may be happening, we have to consider the term called intersectionality. That is that race and social class, and also because we're talking about women's health, gender, all intersect or combine to cause the poor outcomes that we see today. And so when we're thinking about interventions, I have tried to summarize it into 5 main factors. We need to consider the economic limitations or the socioeconomic background. We need to consider whether reduced awareness within the individuals themselves impacts on the poor outcomes that we see. How about cultural and religious barriers? Lack of representation is significantly important. And then also racism and bias, a lot of which you will hear in media is being discussed. Now, this is quite a detailed diagram that I created at the RCOG that helped me try to break down these factors that contribute to women's health outcomes. And I divided it into 3 main levels to help me understand where we at the Royal College could interact to try and see if we could improve these statistics. So we have societal factors. What do I mean by that? Well, I mean the education, the income, the housing, the type of jobs that these women do, the things that Sir Michael Marmot's described in his reports that are the structural drivers of health inequalities. Societal factors also include structural and societal racism. So, to explain that further, there's no genetic reason necessarily why all Black women and all Asian women should have poorer outcomes, but we do know that these women are overrepresented in the lower socioeconomic classes of our society. And really, the reason why that is because of the societal racism that we have today. And it's great to see the discussions that we're having at a societal level as to what we can do to upend that. At a health system level, we do know that we have inequality in access to quality care. So for example, in maternity, we understand that seeing a midwife early at and around 10 weeks of pregnancy significantly improves the outcomes for women in later pregnancy and indeed birth. But we know in many areas of the UK, that is not always achievable. And particularly for women of lower socioeconomic classes and minoritized groups, there tends to be a delay in them accessing early antenatal care. Within the academic system, we know that there's a limited scope of academic research. Often research around conditions that predominantly affect Black and Asian women tend to be limited and few and far between. So for example, research around sickle cell disease or fibroids is extremely limited, which means that the burden and the morbidity of the disease is still extremely high. And this is where we can consider the role of institutional racism within medical healthcare, affecting access, treatment, and experiences. So an example of that is how we characteristically assess babies when they're born using an APGAR score. Part of the APGAR score teaches us to look at the skin color of the newborn baby to try and determine whether we can see signs of poor oxygen. Now, in newborn babies of darker skin, that's much more difficult to determine. And so thinking about where lack of inclusion, institutional racism, or just omission affects the outcomes of individuals is important for us to improve our outcomes going forward. And then there are the individual factors. So we do know that for some groups, there is limited health education and awareness, and indeed the ability to self-advocate. Now, whether that's because of language barriers or because of previous poor experience and reduced trust in the healthcare system, they still combine to produce the same outcomes. And we also know that where there is a limited scope of academic research, this then results in lack of prevention and treatment options that are applicable to a wide and diverse population. So I'm just going to come back to the institutional racism and explore that further. And what we're going to look at here are women's experiences. This report's from the Nuffield Department of Population Health, NPEU, which was published in 2019, looked at women's experiences of maternal healthcare between 2010 and 2018. And I'm just going to highlight some really important points from this important study. They found that in particular, Black women were less likely to receive pain relief in labour, and in particular, Black African women. They also found that these group of women were more likely to deliver by emergency cesarean section. Additionally, they found that women from minoritized ethnic groups were less likely to feel that they were spoken to in a way that they understood. They were less likely to feel that they were treated with kindness, and they were less likely to feel sufficiently involved in decisions and to have confidence in the trust that were providing their care. Now, often this can be dismissed as maybe one study, though it's important to say that this has been replicated in many studies. But I give an example where sometimes omission can have often detrimental effects. Now, you may remember from the previous slides that I pointed out that Black and Asian women were more likely to suffer from a stillbirth, that is the baby dying before it is born after 24 weeks of pregnancy, or a neonatal death, so the baby dying soon after being born. And NICE, the National Institute for Health and Care Excellence, wanted to try and address this. One of the ways that they proposed to do this was to revise the guidelines around induction of labour. And one of the proposals was that all Black and Asian women would be offered an induction of labour at 39 weeks. Now, on the face of it, that seems potentially sensible, because if we are to induce at 39 weeks, we potentially could reduce the significant burden of stillbirth and neonatal death. However, This is a very broad stroke approach, and to my mind is not very good science. And in particular, doesn't necessarily consider the unintended negative consequences of such a policy. So for example, all women who are offered induction cannot stem deliver in the birth centre or have a water delivery, for example. There were some concerns as to whether induction increases instrumental deliveries or indeed emergency cesarean section. And whilst that has not been proven to be true, it is fair to say that it does require these women to be hospitalized for their care. And this has significant impact on a woman's pregnancy journey and her experiences of delivering a child compared to if she were to have a spontaneous labor. So of course, whilst we want to reduce the burden of stillbirth and neonatal morbidity, it is not fair for us to make such huge guidelines based essentially on the color of women's skin without having proper or better science. I love this slide every time I present it. And it's a good slide showing that our biased attitudes matter. And it's from a group in Cleveland, America, where they looked at the biased attitudes of the clinicians and the patient satisfaction scores after a consultation. Now, society has evolved for us to understand that to have obvious explicit bias is not acceptable and is not desired. But what we don't understand, and what this particular slide shows, is that those of us that hold internally explicit bias, it is still readily visible to patients during a consultation. Patients, whether they come across a doctor who is obviously biased or racist, or has very minimal racism and bias, tend to have the same high satisfaction scores, which is interesting because it suggests that where a patient comes across a clinician who they feel is particularly biased, they almost maybe feel that they know what they are getting and maybe don't return. But where a clinician reduces their obvious explicit bias, but still holds high implicit bias, this is still picked up by patients and the satisfaction scores are really low. So really what this shows is that it's really beholden for all of us that work in healthcare to work on our external as well as our internal biases. And that is all healthcare professionals, irrespective of which ethnicity we are. Now, it's not just about looking at the bias within healthcare professionals, it's also important to look at the diversity of healthcare professionals as well. This study, again, from a group in America that was published in August of 2020, was actually incredibly shocking, even for me. And what they found was that Black babies were more likely to survive when cared for by Black doctors. Now, I mean, that's interesting. And for me, the first thing is that really that does require better research, of course, and more research to really understand why. Now, there can be a number of things that we could postulate. Is it that Black women feel that they have and form better trust with Black clinicians? Are they better able to express their concerns around their babies? Is it that some clinicians are better at listening to women of particular backgrounds compared to others? For me, this is so interesting and so important for us to drill down into. But really the take-home message is that the diversity of our healthcare professionals is just as vital to our morbidity and mortality as is reducing bias within the said healthcare professionals themselves. Talking about institutional racism within medicine and often how we can forget where it exists. This great review by a group in Michigan in 2020 shows that the pulse oximeter was more likely to overestimate the percentage of oxygen within the bloodstream in individuals with dark skin. Now, this is incredibly important, not least during the COVID pandemic, where one of the signs of very severe disease was a reduction in oxygen saturation in someone's bloodstream. But if I think about maternity, if somebody is to undergo a significant hemorrhage or blood loss, one of the things that we were characteristically described or taught to look out for was to look for cyanosis or reduced oxygen, which in paler skins can be expressed with pallor or a blue tinge around the lips. As you can imagine, in darker skin tones, that is very hard to determine. And using a pulse oximeter was something that provided us with great comfort and confidence. But understanding that the pulse oximeter itself, that was designed on paler skin tones, may overestimate the oxygen saturations in people of darker skin, is an example of how people with darker skin can often be disadvantaged within the medical space, and really helps us understand why we start to see these poorer outcomes. So it's starting to be addressed. I love this picture of Malone. So Malone's a medical student here in the UK at St. George's, who published a book called Mind the Gap. And Mind the Gap was a book that showed skin diseases and rashes on black and brown skin. Now, you may think, well, that's completely obvious, and why had that not been done before? And to be honest, I can't give you an answer. I remember when I was at medical school and I did actually turn up for my dermatology block, and all of the pictures of rashes and skin diseases were on paler skin, on white skin. And personally, I did remember thinking that if somebody with darker skin presented with a skin rash, the only thing I would be ever confident to diagnose was eczema. But of course, the truth of the matter is that people with darker skin can have all manner of skin diseases. And we must not forget that Bob Marley himself died of skin cancer. So this book was seminal, and I think is a trigger for many more books in the same vein. Really, this is about making sure that we are inclusive in the medical space so that particular groups are not disadvantaged. And this medical student, Chidiebere, is a Nigerian medical student again, who is a medical illustrator as well. And he did this amazing illustration of a pregnant woman and her fetus. And this is the first time, believe it or not, that such an illustration of a Black baby and a Black woman had ever been seen in the medical textbooks. I mean, he's gone on to draw more of these particular diagrams. And for me, I just think it's amazing. But again, for those of us or people outside of the medical space seeing these diagrams, it really helps to make them feel included. So it's important that we have to change if we want everybody to have an equal chance. Many of you may have heard of the advocacy group 5 Times More that came about following the maternity report in 2018 that showed that Black women were 5 times more likely to die. And they've been extremely powerful in this space in advocating for mothers, Black mothers and Asian mothers, and not least getting their petition trying to explore why Black women are 5 times more likely to die to be discussed in Parliament. We know that public advocacy is extremely powerful in this space, but also allies supporting Black and Asian women is vital if we really are going to see meaningful change. This is a picture of the Race and Equality Taskforce at the Royal College of Obstetricians and Gynaecologists that I chair with the President, Eddie Morris. And it's a brilliant and diverse group that involves essentially representation from national governments, from the devolved states, from NHS England, and innovation, which is important to think about how we can evolve medicine for the future to be more inclusive and diverse. And we meet 4 times a year. And we published essentially our key recommendations, which is essentially to ask the government to commit to a target for the reduction of maternal deaths, particularly in Black women by 2023. We're asking the government to commit to an independent review of maternal mortality and morbidity. But most importantly, to commit to robust reporting of quality ethnicity data by all healthcare providers, which is not ubiquitous currently. Some of you may have seen the report published by the NHS Race and Health Observatory that was released yesterday that showed that healthcare inequality exists throughout. So not just throughout a woman's life, but indeed throughout all genders. So this is something that is incredibly important and really runs through the healthcare system like some writing through a piece of rock. And here we are, the NHS Race and Health Observatory that was launched in 2020, on which I sit on the board also. And it's a brilliant group which works to identify and tackle ethnic inequalities in health and care by facilitating research and making health and policy recommendations. And essentially, this group is brilliant in tendering out research agendas, rapid reviews, to really improve our understanding of where we are now and where we need to go. Some of you may have been aware of Birthrights, the main charity group supporting pregnant mothers in the UK that launched an inquiry into racial injustice in maternity care. Now, this inquiry ran through 2021 and concluded at the beginning of this year, and we look forward to their reports, which should come in the mid-2022. And the Women's Health Strategy that was finally launched by the Department of Health and Social Science, which really feeds into this idea of a life course approach, really trying to understand why we're seeing these poor outcomes for all women, but in particular for Black and Asian women. And it's important to note that the report published by Sir Michael Marmot pointed out that for the first time in 10 years, we're seeing a stagnation in the health outcomes for all women in the UK. So women's life expectancy has stalled, and in some areas, in particular to the north of England, we've started to see a decline. So this is incredibly important. The Women's Health Strategy launched by the government, which is a vision strategy at the moment, has 6 areas of focus, and focusing, as I said, throughout the life arc of a woman. So looking at menstrual health and gynecological conditions, fertility and pregnancy, the menopause, healthy aging, mental health, and the impact of violence on young women and girls, which, as you know, is particularly pertinent at the moment. This particular diagram is a very detailed diagram showing how all of our identities intersect really to impact on the outcomes that we have. But in particular, using the lens that I have been using for this talk, it is race, ethnicity, and gender that really have the most significant outcomes, and then underlying all of this, socioeconomic status. And so the main question, the question that I repeatedly asked, what can I do? Well, the first thing is that you've turned up for this talk. So this shows me the level of interest that you have. And it's about replicating some of the ideas that have been put forward in this talk in your own groups, so that what we have is almost an exponential effect of improvement of knowledge and understanding of where we are today. And really understanding that, as it is in the UK, we do have differences in outcomes within our healthcare system. But this is not something that we should feel comfortable with. In fact, this is something that really now requires all of our efforts and our energies to try and impact on in a meaningful way. So I'm coming to the end of my talk, and I just put here some 3 main pieces of reading that I think for anyone who is interested and wants to read a little bit more is particularly good. They all are by Sir Michael Marmot, who I think is brilliant in this space. He was the author of The Health Gap, which looked at the challenges of healthcare provision within Western society, but also his reports Build Back Fairer and the Health Equity Report, I would really highly recommend. And then finally, it's just to say thank you for listening to my talk, and I look forward to the questions and answers that comes after this. Thank you for listening.
Christine, firstly, thank you so much. That was, a really fascinating summary of some really complex issues there, and I appreciate that there's an awful lot more that can be said about each topic, but it was really, really thoroughly interesting. So thank you so much. we do have a few questions. Quite a few of them are on similar vein, actually. One's come through about APGAR scores in particular, the APGAR score in particular in respect of skin colour. This is from an anonymous person. It seems like such an obvious problem that from a layman's perspective and could be remedied without delay. Is this something that is being looked at? And if not, is there something preventing that?
So actually it is. As part of the maternity stakeholder group within the NHS Race and Health Observatory, we are looking at redefining the way that we perform this very important task, which is being able to assess a baby at birth and assess a baby at birth for well-being. Now, you know, as medicine evolved, when it was created and evolved, essentially it was created with the on the basis of white men, essentially. So this is where and why we see the disadvantage of women overall, and then people of darker skins. It's taken us a long time to acknowledge the trickle-down effect into outcomes, but we are now starting to acknowledge this. And things that seem very obvious to us now, we almost seem quite incredulous that we never considered that before. Now, unfortunately, we can't go backwards, but we can move forwards. And just to say, the APGAR score is being looked at as we speak.
Yeah, and I appreciate it's not something that is obviously fairly clear with hindsight, but I imagine, you know, something that's been so ingrained in medical care for so long. There's other questions of a similar vein to that, actually. For example, the generalisation in education that you mentioned in particular. For example, I think you mentioned about fibroids mainly affecting white women and endometriosis mainly affecting Black women. Is that now something that is, as you mentioned, something that is starting to be addressed in and filter down through and into education?
So again, often when I answer this question, I also have to be honest that I am a healthcare professional, and sometimes maybe consciously and unconsciously, I've also perpetuated these stereotypes. You know, when we go into medical school, we are taught and we take what we are taught as a given. We also have to remember that as doctors, part of what we do is to be able to categorize. So when an individual comes in front of us and presents with disease, essentially we are making these quick judgments, a bit like a computer, I suppose, to be able, first of all, to understand this is person at high risk of death or severe disease, and then to try and determine what we think is more likely to be the cause of their condition. So there is a reason why we do this. However, often what we do not consider is that when we make these generalizations, of course, they are just generalizations, and often we get it wrong. So again, a very good example I give is we will often, and we do know that cystic fibrosis, a genetic condition that primarily affects Caucasian people, what we were told only affects white people. And I remember reading an article of a child who presented over and over again into hospital with failure to thrive. Now, our understanding of cystic fibrosis and the way we diagnose it has evolved to the extent that most children are diagnosed, if not at birth, within the first 1 or 2 years of birth. This child was 7 years old and kept presenting in and out with quite classic symptoms of cystic fibrosis, but was never diagnosed as such. Now, at a certain point, a chest x-ray was taken and somebody saw the chest x-ray and questioned why a child had quite progressed findings of cystic fibrosis, having not seen those changes in a child of 7 years old. Now, of course, the person looking after that child now realized, because of course their bias had been challenged, and they realized that this particular child has cystic fibrosis. Now, why was this child not diagnosed? The child was not diagnosed because the child was of mixed race origin. And so again, it just shows quite clearly that by taking away the bias, that is having the person in front of you and the skin color, a diagnosis that really should have been made 7 years earlier was more easily made. And so this is a great example as to how these generalizations can be extremely dangerous and problematic. Now, within medical education, we've been working hard with some medical schools to try and challenge these ways of thinking, and particularly for the fact that we are living in more diverse populations. So, for example, my niece and nephew are half Nigerian and half Vietnamese. And this is quite a common sort of mix that we see in and about our cities and our towns. And so we have to widen our scope of understanding of what type of disease affects which type of people. But it's a long process. Sometimes old habits die hard, particularly for more established clinicians. And that's why it's important for us to really start from the root and start to work with medical education and the curriculums in particular.
Yeah, it's not an easy task. I can imagine it it's very easy to say it, but it's quite a big undertaking. We do have some other questions that are coming through. Elizabeth Duff has asked, so postnatal care appears in the 6 focuses of the Women's Health Strategy. Can you say a bit more about what should be done here and who should take the leadership on this key time for women?
It's a really good question. And the first thing, again, to reiterate is that the Women's Health Strategy has been published as just a vision, almost blue sky thinking on what we would like to achieve. Now, if I were to consult in that particular area, one of the things I say we really need to focus on is the way we listen to women. Now, often in this space, people think that we need to come up with very elaborate solutions, technological advancements and AI to reduce bias. But actually what we hear over and over again is that Black women in particular, Black and Asian women, do not feel heard, do not feel that they are treated with the same kindness and the same value as everybody else. Now, having a baby and being on a postnatal ward, for anybody who's ever entered that space, it's not a particularly nice time. You're tired, you're overwhelmed, you're trying to adjust to a newborn baby, and many women, quite frankly, just want to leave as soon as they can. But they're often very vulnerable and they need help and support. The truth of the matter is that we also are in a healthcare setting with a lot of pressure in terms of our staffing, a lot of burnout within our staffing. And we all know that when we are tired and when we are overburdened, actually one of the first things to go is our kindness and our ability to listen and to show empathy. And this is something that we often see, particularly within our postnatal spaces. So if we are going to invest in our postnatal spaces, then really what we need to do is to invest in our staff, to increase the staffing, so we don't have one midwife looking after 5 or 6 particularly ill women, so that the midwives have time to spend with the women. And really to remind all of us that work in healthcare that irrespective of somebody's skin, actually they are an individual. One of the things I often mention in these talks is that we have to be wary about typecasting people in groups as Black or brown or Asian or white, because even that in of itself does a disservice to the women that we're talking about. Every woman is an individual that has her own sets of needs, her own particular concerns, her own worries. And really, if we treat that individual with value, then I think we will make such significant inroads.
Thank you. I mean, actually, that's a really common theme that we've seen throughout the webinars we've had so far. All of our speakers have talked extensively about how the woman as the individual needs to be the focus of the care. So, absolutely. Thank you. Couple more questions, if that's okay. We've got one from Ella Kane, who has asked, has the NICE induction of labour guidelines update been published, and have the proposals to induce Black and Asian women at 39 weeks been reconsidered?
Yes and yes. And that particular suggestion was dropped, not least because of the distress that it caused many women who potentially would have been affected by it. But then those of us that were consulted, put together a good report for NICE to help them understand that whilst it may have come with good intentions, it clearly wasn't thought through. And not least because of the impact on women. Really, you have to think that if you're going to expand your offerings for induction of labour to whole groups of women, then you have to invest along your whole pathway. So there's no point inducing a whole group of women in the labour ward, but you don't invest in your postnatal ward, because actually all you're doing is shifting their risk from the point at which they deliver to the postnatal points and care. And clearly there wasn't a thought about how they were going to increase capacity and funding in the postnatal setting to account for this extra group of women that you were going to induce. So on that basis, it was dropped.
Thank you. We have another question as well from someone, an anonymous question here. Is there any efforts by groups in the UK to look at examples of how other countries, such as USA, Australia, or New Zealand, are successfully addressing racial inequalities in reproductive health?
So the only country that's really meaningfully trying to move in this space is the United States, which sort of goes without saying. And that's not to necessarily say that they are better in terms of their outcomes. In fact, we know that their maternal mortality statistics are even starker than ours. But what is different is the amount of discussion and exploration. So you may all have noticed that many of the studies that I quoted in my talk come from American institutions, namely from the East Coast, actually. And so the NHS Race and Health Observatory is working closely with many institutions in the US to try and really share learning, actually, and ultimately for us to pool our data, because the larger our pool of data, the stronger our findings are. What is interesting to note, and again, it's important for me to stress this point, is that the findings that we see in poorer outcomes for Black women very much is only really replicated in Western societies, or in societies where these women are overrepresented in the lower socioeconomic groups, or really where there is racism. So when we try to look at these same statistics in a larger geographical area where there are Black people, i.e., for example, in Africa and Nigeria, we don't necessarily see these same statistics apply. So really, what does that tell us about Black and Asian populations that are immigrant populations into Western societies? Well, actually, it tells us a lot.
Yeah, I suppose it's an enormous amount of research and undertaking to go through all of it, actually, keep on top as well. Thank you. One more question come through. Please, can you give me examples of UK policy that specifically address racial inequalities in maternity or maternal healthcare? It's quite a large or open question.
So there's no specific UK policy apart from to say that, of course, within the NHS and NHS England, of course, their desire is to treat all women with the care that they deserve, and to treat all women the same. There is no national specific policy, but some trusts have implemented particular interventions at their high-risk groups. So, for example, in one particular trust in London, they have implemented extra scanning for Black women in particular during their pregnancy to try and see if we can increase our detection rate of babies who have a greater risk of stillbirth, essentially. Now, there are pros and cons, again, to that approach, not least who determines who is Black and who isn't. For example, if somebody is mixed race, does she still fall into being Black? Or if a grandmother was Black, and so on. There are lots of pitfalls there. We also have to recognize that in certain areas, there are also other groups that are particularly high risk. So not necessarily by way of their skin color, but because of other factors. So for example, Eastern Europeans or migrants, asylum seekers, or traveling groups also have extremely poor outcomes, but don't have darker skin. So are we disadvantaging these groups by primarily focusing on Black women? That's not to say that, of course, that Black women have these often worse statistics, but how can we best spread our limited resources to be able to capture all women that are at risk? And of course, many women, rightly so, don't like being defined solely by their skin color if they're otherwise low risk. Some women, don't want to have extra scans just because they've been identified as Black and want to be treated, quote unquote, as normal. So there are lots of psychological, social implications of such an intervention that really have yet to be explored.
Yeah, thank you. That was a really interesting answer. It's it's difficult, I suspect, to juggle the funding. You've got limited resources. It's very difficult. I think we've got time for one final question. And Ella Kane has asked another question here. Are there any particular strategies that you have used in medical education for trainee clinicians, which you think could translate to midwifery education?
So around 2019 and 2020, implicit bias training was very popular, and it came over from America. But subsequently, what we found is that implicit bias training has no impact on the bias of individuals who undergo that training. And so the question is still left unanswered as to the best way that we can deal with individual bias. I mean, personally, my answer to that is really, it's less about healthcare institutions and more about us as society, because ultimately, as healthcare professionals, we are drawn from society and we only reflect the society in which we live in, which is why the conversation at the societal level is incredibly important. It's also why it was not surprising, but disappointing that the government report on institutional racism claims that institutional racism didn't exist. So it was a missed opportunity really for us to have an adult and mature discussion that we tend to shy away from here. But yet America does have as a reckoning. And I think what that does is it sort of keeps us in this grey area. And then in particular institutions, and it's not just medicine, if we look at education, if we look at policing, and of course some of these particular data has been recently shared in the news, we find that we still see these differences. So I think really as a society, if we, until we get to that place where we can have these honest and they are difficult, but honest discussions, we may find that we continually have this problem.
Yeah, and I mean, actually, that's one question that Camilla has asked, actually, that the target to reduce inequalities in women's healthcare outcomes by 2023 relies on the acceptance that institutional racism does exist, but it's something that the government has not recognised at this stage. So.
Sure, but for me, actually, I think the government's recognition is not of interest, to be honest. I think it's those of us that work within the major institutions that really drive the change. So that is, for example, the Royal College, NHS England, NHS Race and Health Observatory, that really have the leverage and power. What the government says is, governments come and go anyway. So,
well, I mean, absolutely, and I mean, thank you very much. I think we've reached the end of the webinar now. That I know if anyone else has questions, we've had a lot. Please email me them directly, and I will see if Christine has time to answer them. But just finally, I'd like to say big thank you to everyone attending today, and most importantly to Christine for her really insightful and fascinating talk about some really important issues. This is recorded, so I will send a copy out to everybody afterwards and make it available on our website too. So that's it from us. Thank you very much, and I hope you all have a lovely afternoon.
Thank you.